of collecting post-market survey data, so namely with all the adverse events, but not only. Of course, the insurances are an important player, and there are the private insurances, the mutualities, and also the RISIV INAMI in Belgium, so the state insurer, which role is to reimburse medicine and medical products. And of course, citizens are also data generators with more and more medical devices or connected devices that generate a series of well-being or actual healthcare data. And then you have the authorities. But as I said, finally, the amount of data in the hand of the state is very limited. And also, all these stakeholders pursue different goals. So, of course, the healthcare providers, they want to provide a better healthcare or to have more time to spend with the patients. Academics, they want to innovate in the medical field. Companies, they want to put new services and products on the market. Insurance, well, they want to bring services, financial services to the population, and also in some cases make profit out of it. Citizens and authority may have, depending on the moment or the topic, they may have somehow divergent objectives. So, for example, citizens are at the same time taxpayers, in which case they will want a healthcare system which is as efficient as possible, but there are also patients, and in that case they probably want something slightly different, which is the best healthcare possible, which may maybe in some occasion cost too much for society. And it's the same with the authorities. They have the mission to provide public health services, but on the other hand, they have constraints related to the budget they can allow. So just to summarize, we have a fragmented legislation, and the data are located in multiple data silos, not all interconnected. For most, they are not interconnected. And let's not talk about interoperability. So actually, the state has a limited influence over a limited set of data. So it may look a bit despairing. In that situation, are we facing a wall? What can we do to overcome this scenario? That was a bit the question raised in the context of the Digital Minds program set up by State Secretary Mathieu Michel, who launched a series of working groups. There are groups on many different topics, educations, transportations, etc. There is one group dedicated to the use and reuse of data in Belgium in general. And there is this group related to health data in particular. The reason why there are two groups related to something about the data is because there are specificities related to the health data, and also healthcare is one of the key activities, also from an economic standpoint in Belgium. Belgium is a worldwide champion in innovation in healthcare, and overall, although it is not perfect, we have a very good healthcare system as well. And so it was thought that it would be good to have a specific group dedicated to that topic in particular. So the group consists in about 15 persons, which are representative of most of the stakeholders that I just listed before. And also we try to gather persons who have each multiple hats with long track records and various experience, if possible, in several of these different stakeholders. So, for example, we have people working in academia, and before that in private companies, or in a hospital as responsible for IT, but also as an actual medical practitioner. So a very interesting group of persons, covering also all the regions of Belgium. in the context of that group, they generally speak in their own name, not in the name of their institution, of course. And also, as we are frequently reminded, before we are professional, we are also citizens and taxpayers. So that also is taken into account in the course of the meetings. The group has been constituted last summer, and will still have some work to do in the months ahead, but is expected to finalize its mission during the coming months. We can draft very ambitious roadmaps completely disconnected from realities. And I'm sure we all have very bright ideas about how the healthcare system should evolve in the future, thanks to all these technologies. We also wanted to do something more specific and more actionable by also integrating in these reflections actual facts that have to be taken into account in this particular landscape of the Belgian health data. And so, among other maybe broader reflections, we also took the time to go through a series of current legislations and upcoming legislations, so texts that are currently being written. Some of them are directly related to health. Others are more general, but have an impact on health data and their use. I list here a series of topics that we have discussed. So we have been connected with the Belgian Health Data Agency that has just been created a few weeks ago, which was intended to be at first Belgian Health Data Authority, but given the perimeter of its missions finally is named Health Data Agency. There is a federal AI plan also, which has been reviewed. The open data law that already exists, but is currently being reviewed as well. More technical laws, such as the law intégrateur de service, so service integration, who states how the recognized data silos can connect to the IT architecture of the state. Sandboxes, which is a new concept that will allow potentially to test innovation on actual data, but before these innovations get to the market, so in some kind of closed environments. We also have looked at texts that are written at other levels, and namely at the EU levels, and namely the AI Act. And there are a lot of talks this week on this particular piece of work and other EU legislation. So just as, for example, the EU Health Data Space Project. And of course, this didn't prevent us to also come with more broad consideration that we will cover in the next slide, namely to be able to reuse data, you first have to have the data. So the first use before the reuse that I will discuss. Also build trust at all levels, because you cannot speak about reusing health data without building trust in all the stakeholders. There is also questions related to the reimbursement of data-driven health innovation, with this particularity that unlike with therapeutics, for example, all the field of medical device or diagnosis will require data in the first place. And that is also something that we will discuss in this presentation. In total, we listed more than 30 recommendations that are currently being reviewed by Secretary of State. I will not detail them, first because it's not the time to do so, and also because that would be too long, but I will pick up some of them during this talk. Also, what we witness is that it is not always possible to have all the stakeholders 100% aligned on the message and the recommendations that we could draft. Sometimes people are more in favor of some recommendation and others are more reluctant. Just reflect the multiplicity of experience, expertise, and objectives. So first, we got interested in the first use of the data, primary health data, and we reviewed a very interesting study performed by the Fondation Roi Baudouin. It is very interesting, this study, because it shows that maybe contrary to what is believed, actually people are in favor of sharing their own health data. They are not reluctant to do so. And you see at the first line that if it is for improving the quality of their care, almost 90% agree to share their data. So that is maybe more obvious. What is less obvious is that more than one person over two, so more than 50%, would also agree to share their data with pharmaceutical companies to develop new treatments. So that is somehow good news. People are willing or open to share their data, even for commercial use. Of course, commercial, because in the end, it will also have a positive impact on health. So that is interesting. And by the way, Fondation Roi Baudouin is also part of this work group on health data. The next question is, okay, but if people agree to share that data, why actually can they share as for now? I made the exercise because some of the data, the health data, are plugged into pipes, allowing them to flow to citizens. And everyone in Belgium can go to the Ma Santé, My Health, portal, and provided that you have It's Me or an EID reader, you can have a look at your own data. So I made the exercise. These are my own records. So fortunately, I am in rather good shape, but still, you see here that over the last 8 years, there are only 14 records regarding my health, which is completely not reflecting the reality. And moreover, more than half of these records are related to COVID tests. So, okay, it had been very important to make the results of these tests available, but I mean, it is not the only thing that we want to know about ourselves. And so that is the first point, is that the platforms that exist in Belgium to make the health data flow are in place, but likely not fully exploited. And you see also, for example, in the column here, disponibility, some of the records I know they exist, but I do not have access to them because the healthcare practitioners has the right to decide that I cannot see my own result, which is, in some cases may be argued. I'm not in favor of blocking the access, but it can be argued in some cases, but not in most cases. And here, for example, you see a COVID-19 test result. I cannot possibly understand why I should not be able to access the results. That's why I made the test. So by the way, all the information pictured here are not centralized. So these data are not in a database from the state. They are just interconnected via a quite complex series of interoperable systems. And you see some of them here. So COSO, Réseau Santé Wallon, Vitaling, etc. are entities to which the actual healthcare practitioner push the existence of a medical record, and these networks, COSO, Réseau Santé Wallon, etc., they just push to me the fact that the information exists and where I can find them. So it is a decentralized system, which is perfectly fine. It is great, actually, but clearly a lot of data exists. And so to improve that, because we argue that there is a huge need to improve that, it means that maybe we can argue that the user experience may be a bit refined, more modern, etc. Yes, but most of all, what is missing so far is that all the other entities play the game, So, for example, I cannot see in that list of medical records things that I would have fetched at a pharmacy, for example. My vaccination data, we had several vaccinations campaign during COVID, but also more regular vaccination campaigns should be reported. And so, for example, you have Vaccinet who has the information, but doesn't push it to these networks. Same thing for mutualities, Red Cross, all the most of the medical image centers do not push their data as well, although they could. And it would be really a benefit for each citizen to have a more exhaustive view on the various records that are generated throughout the life of a patient, and how could it be possibly done that people agree to share their data if they have not access to their data. And on top of, so the first list here is a series of registers that are more professional, but we could also think about giving to the citizens the capability of mentioning themselves information in the system. And maybe they should be labeled as such so that we can make a distinction between data that is pushed by a healthcare professional and data that is pushed by patients. But there are likely valuable medical device used by the patients themselves that could also be interesting to gather there. So that is the first step, would be to use what exists, but in a much more extensive way. The second thing is to boost interoperability. So the Réseau Santé Wallon and the COSO, as I explained, have made a quite important effort to standardize the way they communicate information, or at least the existence of information. But we have to also remember that in Belgium, a few years ago, a choice has been made to not impose a common set of medical softwares to the healthcare practitioners, and somehow that's good. Each institution is free to opt for the solution it thinks is best, and there are funding associated to these softwares. The thing is that if you fund the acquisition of digital solutions for the healthcare practitioner and you let them free to choose their own solution, then you also have to integrate in the reflection the interoperability between those systems that are left free of choice. And that action of making these systems interoperable is time consuming and also budget consuming. So it means that the institutions should get funding just for that. And also that the state continues, because it started already, but continues to produce guidance and standards for the interoperability of this various system. I list here a very nice example of what should be done everywhere, but it's clearly not the case everywhere. So it's just one example. There are other good ones, but just took one. So, for example, the CHU of Charleroi is the first hospital to have implemented the national medication scheme, which is precisely a framework to standardize the storing and exchange of the medical acts. And has also a portfolio of connectors that can be reused by other entities and that are actually used by 70 other hospitals. But 70 hospitals, it's about the third or the quarter of what we have in terms of hospitals in Belgium. They also work at CHU Charleroi to interconnect the hospital practice with the first line medicine, so the general practitioners, and namely in collaboration with another software provider, which is MediSpring, which is actually a collaborative initiative by general practitioners. So there are good examples, but that should be brought much more forward for all the institutions in Belgium. Another very important point that may be not obvious is that we have to focus on medical device and in vitro diagnostic if we want to have an important wave of innovation in medicine. So the reason why we have, and we still have in Belgium, a very active and very prominent and recognized pharma industry is because 30 years ago, Belgium was the most performing country in terms of clinical studies. And also Belgium has put also tax incentives related to that activity. It just not happened by magic. There are precise measures that have been taken. And it is important that we realize that if we want that to be carried on, we have to focus on where the next waves of innovation will come. And if we speak about AI and data, it will be maybe in the discovery of new drugs, but most of all, it will be in prevention and diagnosis and home care. And all these innovations are related to other kinds of medical products, which are medical device and in vitro diagnostics. And that's what's reflected by the AI barometer presented just a few minutes ago by Giovanni Briganti, who showed that the perception of general practitioner is that precisely the AI-based innovation was going to happen in prevention and diagnosis. And reflecting that, the FDA, which is the Food and Drug Administration in the US, but also Health Canada and the Regulatory Agency of Healthcare Products in the UK, commonly wrote a guidance which is called Good Machine Learning Practice for Medical Device Development. I put that just to show how important these AI-related innovations will be in that field. And it is the same for the GAM5, which is a guidance on how to develop a computerized system that should be GXP, so good clinical practice, good manufacturing practice, etc., which in its new edition of summer 2022 added a brand new appendix just on artificial intelligence and machine learning. They say, okay, somehow AI innovation is partly what we already know for software-related innovation. So, of course, some implementation aspects are similar, but there are other aspects that should be taken into account that are very different. And one is the data-first concept. So, for example, if you develop a drug, then you do your research generally in an academic context, then you will have a proof of concept, you will go through all the research phase, and it is almost at the end of the road that you will start doing clinical studies and generate data on people. So generally it is already commercially almost ready before it gets to clinical study. When you want to develop medtech innovation, medical device and diagnosis, in general, you will require data first. That would be the first step, is to gather a data set on which you will learn your new diagnosis test or image recognition setup. You will start with data, and that poses, of course, different challenges. So first, we have to work, as we just said before, on the access to the data. But also, it requires a change in the way clinicians, and in particular clinicians who are involved in research, be funded. So for the moment, clinicians do their work. And when it comes to their research work, a large part of the funding comes from companies, because when you get to phase 1, 2, 3 studies, in general, the institutions responsible promoting these projects are in general private companies with already consequent funding. In the case of medtech innovation, it will not be the case, and so we must reflect on how to better fund clinicians who want to take part to medical innovations of tomorrow and help other researchers to access relevant data. Another particularity is that in Belgium, it's not the sole country working like that, but it's particularly true in Belgium. reimbursement of medical innovations is performed in silos. So you have one budgetary silos for therapeutics and another one for all related to medical device and for diagnosis. And in particular, you have to show that the product you want to put on the market, after having shown that it is safe and effective, you have to show that it will generate economy, budget reduction in the same silos. But it will generally not be true that a medical device brings economies in its own silo. It will, for example, prevent a disease from happening or prevent the prescription of that or that drug or recommend one drug rather than another. So the gains are rather in another silos. And this really needs to be addressed. I hear for 15 years that it will be addressed. But if we do not address it now, then we will lose a series of companies developing promising medtech technologies. And for example, you have already multiple Belgian companies who finally have to go abroad in the US to promote their technology first. You can think about MDX Health for a rather older case, but more recent, you have Bloom Life or Gabi Smartcare, who clearly, although coming from Belgium, with all the bright minds that we have here, have to address first the US market due to these market access issues. And so if we see the link between data-driven innovation and funding of where these innovations are going to apply, then we need to clearly address the structuration of this innovation, its funding in Belgium. The last point I want to cover today is the open data framework initiated by the European Union. So you have this very interesting text dating from 2019 on open data and the reuse of public sector information. So what is the principle behind that piece of work? It states a very powerful and very simple principle is that anyone in Europe should be able to access public sector information in real time, if possible in a programmatic manner, so through APIs, not only download of files, not only the data, but also the pieces of softwares that were used to generate the data. And that is without conditions, for free, for all. So that's very powerful, that's very bold, I would say. So is it really all the data and all the software? Yes, but of course there are some reasonable restrictions. So for example, it cannot be private data. You cannot ask private data on citizens, for example. And with respect to the pieces of softwares that the administrations will have to share, of course, they may not share softwares that are subject to copyrights or specific licenses. But these are basically the two main exceptions. And is it really for free? Yes, that is clearly written. The sole exception is that there may be a cost that is charged to the requester if there is a specific work to assemble the data, if it has not been so. But even in that case, it is stated that it is a marginal cost that should be charged. So this, in principle, is related to public services. Yes, we have a question.
About the open data and the software and the copyright, does that, in the interpretation, wide interpretation of the law, forces the European institutions or European, like national institutions to use open source software data to finance the development of open source software, public institutional data, etc.?
Yeah. Okay, so I will repeat the question. So the question is that is it a consequence of that text that public institutions have to enforce the use of open source software? Is that okay? Of free software, yeah. So of course, it is a very interesting question, because if we do not enforce that, then somehow that part of the text would be without effect. So the text doesn't say that, but if you ask at the level of Belgium, for example, it is now integrated not as an obligation, but as a good practice to use open source or free software when available and when relevant. But of course, it is a very good point. Now, this is a European text applicable in theory to public sector agencies. So now it is currently being integrated in Belgian law. And before that version of the European text, there were already other European initiatives that, in the same spirit, that were already translated in 2016 in Belgian law, and in particular in a law called PSI law, which basically says the same: public sector information has to be made available to anyone. The trick is how are defined the notions of public entity. And there is where it gets very interesting, because in fact the definition is very broad, and in practice it encompasses any entity who must have recourse to public procurement, and also those who address a general interest. And this is in the very broad sense, so it is regardless of if that general interest is actually stated in its statutory documents or not. And so if you read that, you have maybe already understood that hospitals will fall in that category, universities as well, and a very broad list of foundations, associations, etc. In fact, and already today, that is regardless of the updates of that law that is upcoming, already today, we have a Belgian law stating that all these data should be made available to any requester. So that is also something that we recommended to work on, is the publicity of that law, and, for example, a solution for any entity to assess if itself falls in the scope of that law, because of course it is written in a law expert vocabulary that may not be accessible to anyone. So that is potentially very impactful for the unlocking of health data in Belgium. Fortunately, we also have support available. So anyone can contact BOSA. So BOSA is the transversal federal public service, namely in charge of digitalization matters. And they have their portail fédéral des données ouvertes, where a huge set of resources are available. And they are also available to provide guidance in this maze of legislation and concrete tool to access data. They also can play a role in logging and comparing similar requests that would have been made, so that two similar cases do not get very different answers from the data controller or the data owner. And similarly, but that depends from the Ministry of Interior, there is the Administrative Document Access Commission, and there also, if you feel, for example, that one of your requests has been negatively answered, has been refused, and you feel the argument is maybe a bit weak or completely wrong, you can contact them. In particular, and especially when it comes to health data, a very frequent opposition is no, we cannot satisfy your request because it will infringe GDPR of and privacy and medical secrecy. In most cases, or in a lot of cases, this argument is brought up too easily, and sometimes in an exaggerated manner. And so certainly these administrations can help to make that more objective. And we hope that the Belgian Health Data Agency will take also that as one of its missions in the upcoming months. And that's it for today. If you have questions, I'd be happy to answer them. Yes? There are plenty of technical solutions to make the data interoperable. The challenge is more a management challenge. How do we ensure if we want to at the same time keep a lot of freedom among the data owner or controller, if we want to still maintain a lot of freedom, how do we drive all these institutions toward common standards? It's more that the real challenge. Yes?
I'm a big proponent of open data, but at the same time, I understand in the amateur philosopher, with the great power comes great responsibility. Are we, like, do we have anyone working the same way as there's like this morning, important researchers in AI saying like, hey guys, we should slow down on AI testing because we have no clue where this is going, the brightest mind on earth. I feel like open data, having open data about how schools work, hospitals work, airports work, train stations work. I'm no terrorist. If I were a terrorist, I would definitely use that to make like explode all of Belgium in one thing. I would know whenever everyone is at school, in what classroom, and that is not covered under GDPR. I know how many students are in that thing, in that plane, in that waiting room, especially with all of those IoT stuff and the fantastic, ironical 5G development. So we will know it at the very second. So I know that there will be one more person coming in the room before I detonate the bomb. For example, that's just like one terrible use case of open data. Is there anyone, my question is not even like, is it possible to do it if we do open data? It's like, is there anyone thinking about limiting those use cases?
Yeah, yes, I think that most people are very aware of these potential very wrong developments. Here, for example, no one speaks about sharing massively personal data, medical data. So the example I showed with my own records, no one has this complete database. Only I has the possibility of logging all these events that are spread into multiple silos. Maybe if we generalize the assembly of those data, that would become dangerous, but that no one proposes to do that. And even when we consider the open data law, there would not be personal individual data that would be shared. It would be, for example, of the like in your hospital, how many CT scan do you perform on that and that kind of populations, for example, or what are the use of prescription of biologics in rheumatoid arthritis at a maybe more finer grain, but not at the individual level, of course.
Exactly. But outside of the framework of GDPR, so if we remove all of the data that is covered and that would not be put under open data in an open data framework, such as patient data, such as pupils, individual data in schools, etc., we would still be able to say like there are 15 students in that classroom, in that school, or there are this number of exams, CT scan exams in that hospital. And so if I want to do like a physical denial of service attack on a hospital, I would be able to do it much more efficiently because I know exactly the fragility points of that structure. Same for the drugs. Like we know that for the past 2 or 3 years, there are like lack of data, like lack of drugs. We can bring revolution much easier if we have access. Like this is buying agencies have been trying to collect that kind of information. He put it away for free. Who's the team fighting for good with those open data? Is there like an agency, a federal agency, actually like white hacker trying to?
There are certainly services of the state worrying about security issues, most certainly. But this is a bit an unrelated question. I mean, the AI Act will also make restrictions on what can or cannot be done with the data. Yeah, we'll see how that will evolve in the upcoming months and years. But the intention is at least not to share to fine data, to fine grained data. Yes. Sorry? Yes. No, in fact, it's not standardized. Well, there are standards that are available that are proposed. As I said, that is the great challenge, to align everyone on how, or at least a lot of people on how to make them understandable. And now there are also the question of along with the data, to also publish metadata that explain how the data are structured, to allow precisely someone to pick up different data sets and make them comparable or interoperable. Yeah.
From healthcare data in Asia, we cannot use the same data as for Europe because the gene and the data are different. The algorithm and model should be different. I definitely was the EU level or Belgian level, if, for example, they want to bring this solution here, they need to retrieve model that into the local healthcare data. So is that open to foreign companies to access this data, and how those data were labeled? And also, when information is allowed, what's not allowed, exactly because
so two things about that. On the access to the data, so the open data framework puts no constraint on the origin of the requester. So if you are from the US or from Asia, you will be able to make the same request of access to the data in Europe. Yes. For the other aspect, which is the performance of some medical decision support system, that in fact is already covered regardless of this open data discussion or AI discussion in the MDR and IVDR, so the regulations on medical device and in vitro diagnostic, because you have to show, preferably in clinical tests, that your solution is also fit for the targeted population. And so if there is a scientific rationale to think that in some indications there might be an ethnicity impact on the efficacy of the solution, then you will have to show that in your clinical study that your solution also performs well on these targeted populations.
Research purpose we also found into these kind of regulation laws, because healthcare data we can see for academia for research purpose. One is the real life for pharmaceutical so for research parts, purely research, and is that also found with all these more likely?
As long as your solution is for research use, of course, the restrictions are much lighter because it's research. But on the other hand, you cannot make claims in research use only product that you would make on commercial products. No more questions online? Okay. Thank you, everyone, and have a nice day and week, an AI week.